hear different recommendations from different groups. But it's not because they really disagree on the biology. They disagree on the allocation of resources and how many false positives will we accept in order to get the true positive. Welcome to the Dr. Gill Show. This is the podcast where we talk about medical matters that matter to you. My guest today is Dr. Uma Ramadas. Welcome to the show, Uma.
Thank you, Gil. Thank you for inviting me for the show, and happy to be here. Let me introduce myself. I'm Uma Ramadas. I'm a medical oncologist and hematologist. I work in Missouri Cancer Associates. I've been in the practice for about 17 years, and I'm happy to participate in this podcast.
Thank you, Uma. You, like I, are in a subspecialty of medicine. I'm an OBGYN that did a fellowship training in the subspecialty of reproductive endocrinology. People might know that an oncologist / hematologist like you is also board certified and trained in internal medicine, and then does additional years of training in the subspecialty of oncology and hematology.
That is correct. Yeah, we do complete 3 years of internal medicine. Following that, we have 3 more years of hematology oncology fellowship. Then you're ready to go as a oncologist and hematologist.
Yeah, it's a very complicated field. It requires years and years of training. My specialty and your specialty have something in common. The patients we see tend to be very desperate. They have very important needs, and they need to be treated in the most effective way possible. Of all the jobs in medicine, I think perhaps hematology oncology that you practice is perhaps the most stressful field of all. I'm very impressed by anyone that can do oncology like you.
Thank you. Actually, the word cancer all scares everybody. It is a very life-changing diagnosis, and the moment you hear, a lot of people think that their life is going to end, and they're hoping, we can come up with some treatment we can cure them and make them live very long. And so things have gotten improved over the last 50 years. Every 10 years we have seen cancer death declining because of a lot of advances in screening, better lifestyle, quitting smoking, and exercise. All these things helped a lot of people to prevent or delay the cancer and get a cure also from the cancer by going for the screening test.
Yeah, there's a lot to unpack there, Uma. So cancer need not be a death sentence. And in fact, cancer is one of any number of diseases. How many types of cancer are there, Uma? 200, 300, something like that?
Every organ can form cancer. So pretty much, you name any organ in the body, we can get cancer in that organ. And it's especially the common cancers are breast, lung, prostate, lymphomas, pancreatic cancer, colon cancer, and uterine cancer, ovarian cancer, melanomas. These are some of the most commonly diagnosed cancers, and that we see and treat them.
And there are many different diseases, and you have these blood cancers. So we've got traditionally they call them, they're solid tumors, and then the blood cancers, which is why you need to be an expert in hematology or blood as well.
That's correct, yeah. The way we approach both the type of cancer is very different, and the treatments are different, and their outcomes are different. So generally, when we see people, we have to identify they got their diagnosis right, and we have to stage them, and then we can treat them. The best thing for any cancer is if there anything you can do to prevent it you want to do that first.
Right. Prevention, then early detection.
And those would be the key for taking care of cancers.
So that's a global, that's true across the board, no matter what your disease might be.
That's correct. Yeah.
Now, today we're going to talk about advances in cancer. I had a chat with you several months ago, and it was so exciting to hear about all these latest developments in diagnosis and treatment, and that's what I hope to talk about today. But I'm going to back up a little bit and talk about the traditional treatment of cancers. In the old days, before we had chemotherapies or anything, the treatment was basically surgical. Try to find the disease and get far enough around it, it's called margins, to try to get it all.
That's correct.
So early surgeries for cancer were very disfiguring, and a lot of them were unsuccessful because even though the observable tumor was in a particular location, it had already spread around the body.
Yeah, cancer, as we know, is two problems. One, the problem of local control, and then we have a problem of systemic control. So breast cancer is really a model example of how the surgery for the cancer treatment has improved over the years. Years ago, when people had a lump in the breast, they would go to the surgeon will remove the lump, and then unfortunately it will be coming back. So
Right.
then the surgeon thought they need to remove the whole breast. So they
Right.
removed the whole breast, and then like at the deeper margin, the cancer was coming back. So then they didn't realize what to do. Then they went back and then said, okay, we may have to remove the muscles underneath the breast. So they did a radical mastectomy before. So nowadays, things have a lot improved. Since mid 70s, like we have the mammograms starting to appear, and mammograms screening have widely become available. And now we would see people at the earliest of stages of cancer. So we just have to remove the cancer and get a clean margin around it. Then the local control, we include a little bit of radiation therapy so that the cancer which tend to come back locally will be controlled with the radiation therapy. Then we treat them with either chemotherapy or a hormonal therapy, which has improved the outcomes for these patients much better.
So I'm going to jump in there. So the early days of chemotherapy, there was no way to target the specific bad cells. The strategy was, and please tell me if I'm wrong, was to try to kill the fast dividing cells, which basically differentiated cancer from most normal cells. So if you could slow down or kill the fast growing cells, that would include the cancer cells, hopefully, and give you some chance of treatment. So it was a broad net, it was a scattershot approach. And unfortunately, these early chemotherapies would also kill other fast developing cells, which were your bone marrow cells, which you need, your bowel, your hair, and all the stuff. So you would cast this wide net and unfortunately catch other fish. So what has happened, and I want to talk about more today, is the ability to focus down the therapy so that instead of killing all fast developing cells, you can target just the cancer cells. Isn't that in fact what's happening now in recent advances?
So breast cancer, when we talk about like improvements in chemotherapy for breast cancer, most of the improvements happen in what we call as a supportive therapy.
Well, say that again?
Supportive therapy.
Supportive?
Yeah. So what supportive therapy is like, people used to have a lot of nausea, vomiting. They used to have really low blood counts, and they will end up in the hospital. Some of them even died from it. So, improvements in understanding of how to stop our people from having nausea, vomiting, how to have them stop them ending up and dying from infections, those improvements added a lot more tolerable for the women with the breast cancer. So when we talk about breast cancer, like we talk about like stage 1, 2, 3 patients, and then we have stage 4 patients. stage 4 patients traditionally, some of them will be about 1/4 of them will still be curable, and but majority of the stage 1 to 3 patients will be able to be cured.
So if you catch it early,
If you catch
like
it
many,
early, yeah.
it is in fact curable. The C word, the cure word is
Yeah,
reality.
So curable is that you will not have disease, or and you may end up in trouble with something else.
Sure.
So unfortunately, the thing about breast cancer is that it's a very cancer. It can surprise you in many ways. Somebody will be without cancer for 26, 30 years. All of a sudden, they can come back with the cancer which they had 30 years ago. How can we prevent those patients? Those are all the places where we're still studying, understanding who are those patients, what can we do for them so that this kind of events will be decreased and are eliminated.
Yeah, so traditionally they've had 5-year treatment and 5-year recurrence rate. So after 5 years, they draw a line in the sand and say, well, you're cured, or at least you don't have a recurrence.
Yeah. So if you have cancer come back in the first 5 years, that would be the cancer be more serious to your life. So if you have it come back, several years later, those are the cancer which are traditionally slow growing cancer. You can still keep them under control for years and years. And so this is how why the breast cancer gives jitters to oncologists like me. They will say, "Am I cured?" Well, all I could say is that you're cured until we didn't find it come back.
Right. And since life is 100% fatal, we're trying to delay that until something else gets us.
Absolutely, yeah. Yeah, if you look at the treatments for breast cancer, we are doing less invasive treatments, and then we are able to identify patients who need chemotherapy better now than say 20 years ago. One of the important advance, in development of breast cancer, is a test called the Oncotype DX test.
Say that again, Oncotype?
Oncotype DX. Meaning,
Okay.
And there is another test called the MammaPrint. So these two tests, what we do is we take the breast cancer sample of that individual and we identify their gene expression profile and come up with a score to identify whether this individual will benefit from the chemo or they can safely omit chemo.
Okay, so I'm going to stop right there.
Sure.
So you get a sample of the tumor, and that's sent to a special lab, correct? We don't just do this on the back table here. It's sent to a special reference lab where these new technologies allow the genetics of these actual cells of that actual patient can be dissected and better understood at a molecular level. Because not all breast cancer is the same. So everyone has perhaps a slightly different strain or a slightly different type.
Absolutely.
All right, so this can be done. So there are commercial labs that can now take these cells, and a week or two later, we get a printout, perhaps an email or a portal or something, and you get a much more in-depth biological genetic understanding of this tumor, far beyond what you would get just looking at it under the microscope.
That's correct.
Okay, so continue.
So years ago, we would give chemotherapy for everybody over a 1 centimeter or half an inch tumor. We would recommend chemotherapy for those patients. So
just by size.
Yeah.
Okay.
Just by size, and then if they had it in the lymph nodes, and so now we will take those samples and send it, and then they come up with a recurrence score. And this has been validated in clinical trials where we can use that information to say, okay, this individual has a low recurrence score, even though their cancer is about 4 centimeters in size. And so, this patient would have gotten chemotherapy 20 years ago. Now, we may not give her chemotherapy. And then we also, even if it is spread to the lymph node, if their cancer is estrogen dependent and progesterone dependent and HER2 negative, those are the key factors we look into before we send this test. So if somebody is estrogen and progesterone and HER2 negative, we don't send this test. So it's only for the people who are estrogen and progesterone positive. we can identify the individuals who can safely skip chemo, even if it is spread to up to 3 lymph nodes. So
Interesting.
not all the patients who have gone to the lymph node need chemo. If they are estrogen and progesterone positive, we can identify. There are some people who are not healthy. Like this may help those patients to understand that whether you want to really give them chemo or not. If they're unhealthy, they're not going to handle the chemo well. If they're healthy and if their life expectancy is beyond 10 years, you would want to give them the most aggressive treatment now, so that years down the road they get the benefit of not having the cancer come back.
Well, that's fantastic. So it's not one size fits all. You can now, do you see this getting more and more common? Do you see the tests getting better and better over the years so that we can even more precisely or personalize treatment?
It is improving, and every year, we see some improvements. And in the last year or so, one of the new development is that there is a new group of drug called CDK4 inhibitors, which has come up. So these drugs, traditionally, when we give anti-estrogen therapy to the patients, some of the patients are inherently resistant to those anti-estrogen therapy.
They're resistant to these tamoxifens,
and anastrozole and all those treatments. They may not respond as well. So after a few months or a few years, they may get resistant to that treatment. So we have the CDK4 inhibitors. They help to those patients really who have not responded. It will make them respond to them. So this has come up in the stage 4 cancer patients first. Now we are starting to use it for people with the stage, those involved with the 4 lymph nodes or more, or we consider high risk breast cancer. We would give them those treatment now. So small improvements, every year or so, we are adding more to the patient's treatments so that we can make them live longer and longer.
And I'll just put a fine point on this. As practicing physicians, we need to stay current, and keeping up with the vast body of literature is a big part of our lives. Like if you see me sitting by the pool in the summertime, there's usually a journal in my hand because I'm using that time to keep up on the latest developments. I assume you go to conferences all the time like I do and stay abreast of all these amazing, rapidly developing therapies.
So breast cancer, it's a common cancer. That's why we are spending more time talking about it. So breast cancer also, had a significant development in the form of the anti-HER2 therapy.
Would you say that HER?
Yeah, HER2 new therapy.
HER2 new therapy. Gotcha.
So the cancer cells, they express markers on their surface, one of the epidermal growth factors. So one of those growth factors is called the HER2. If you have a overexpression of that protein on the cancer cells, we can target them, and that will make the cancer cells die faster, and they respond. They live longer. So around 2000 about 1999 or 2000, there is a drug called Herceptin or trastuzumab, which came up for stage 4 cancer patients. Now we are using for early stage cancer patients, stage 1 to, in 2005, one drug for that particular makeup of the cancer showed the death rate from the with or without the treatment is decreased by 50%.
Wow! So I see why Herceptin got its name. It's going after that HER2 target.
Yeah. So that is a significant improvement in the treatment of at least 1 in 5 breast cancer patients will have that HER2 positivity. So that changed how these people got treated, and we see that those are the improvements which were made over the last few decades. We see the breast cancer patients live longer and they die less.
Wow, 50% reduction. That's amazing.
Well, that one particular group of patients. It's not for everybody,
Gotcha. Now I'm going to steer this conversation right now to improvements in diagnosis. Okay. I'd like to talk about that first because the sooner we can get these cancers, the better you obviously are at treating them. So obviously examining yourself, having a doctor check you perhaps once a year. If you're a guy, it's a prostate exam. If you're a gal, it's a breast exam. You see these now. Colon cancer is another very common cancer, and I see these ads on TV for stool tests for colon cancer. Has that been a game changer in finding colon cancer? Because nobody wants to get a colonoscopy. People put it off. I put mine off a few years. So you're supposed to get one at age 50. I put it off a little until my employees actually scheduled it for me, and they forced me to have it. So there are ways of diagnosing and finding cancer earlier than traditional ways. So maybe perhaps tell me a little bit about this new stool test that we see advertised on TV.
Colon cancer, the current standard is to start screening about the age of 45. And, you need to understand, your doctor will know like what risk category you belong to. So if you have a strong family history of colon cancer, you probably want to look into colonoscopy.
Okay, so don't just rely on like you see on those ads, it says if you're at normal risk for colon cancer.
Average risk.
Average.
The average risk. So the Cologuard is a very fascinating technique. Years ago, you go to a doctor, like they will do a rectal exam, and then they put the little bit of a stool on a card and then look for blood.
Just for blood, and lots of things can cause blood.
Yes. So they will test that. It's called stool-buccal blood testing by your doctor. So over a period of time, we realized that it's not really a good test, mostly because they can have a hemorrhoid. They can have a lot of
dozens of other things can cause blood. It's not specific.
Even taking vitamin C would make it possible.
Yes.
So you really, we can't 100% rely on that. So then the step up came, everybody felt colonoscopy is a good screening test. There is not enough gastroenterologists to do all the colonoscopy needed in the country.
So there is a provider shortage for that if everyone were to have a colonoscopy. Okay.
But that is still the gold standard screening test. My recommendation generally would be if you're a high risk, if you have a family history, then you probably do a colonoscopy. If you're an average risk, if you want to order Cologuard really what it does is that it tests the fragmented DNA material in your stool looking for cancer cells.
So it's much more specific. These DNA tests can find the DNA, the fragments that are more specific for colon cancer than other things. So that's something everybody could do.
If you have a positive Cologuard test, you will get a colonoscopy.
You'll get a colonoscopy. But if it's negative, it's reassuring.
It's reassuring that you don't have any active cancer at this time. It does not detect polyps. Polyps are the one which translates into years later can grow into cancer. So that's why doing colonoscopy, if you remove a polyp, you're better off. You saved yourself from getting a colon cancer.
Okay, because you get it right where it was growing.
That's a concept of the mammogram too. So whenever you have somebody going to get breast cancer, you can see a series of changes. They start as hyperplasia, which is growth of similar normal-looking cells, then that transforms into dysplasia or a carcinoma in situ, and then transforms into the invasive cancer. So it goes in stages.
And how early can a routine mammogram find those early changes, Uma?
It is not foolproof, but you can see the changes on the mammogram as early as atypical ductal hyperplasia.
So it's not even cancer yet, but you can see those little calcifications, little changes, and catch it super early. Now with skin, I believe going to a dermatologist and not having just look at your face, but you literally get in a robe and they look at every square millimeter of your skin. Is that still the best screen for skin cancer?
Yes. Yeah. So because dermatologists have much more trained eye than your regular doctor, and all the moles, for some doctors will look alike. You can't tell what is a bad mole compared to a regular.
Right.
Yeah. So dermatologists do use like a dermoscope, like which has a special infrared light they use these days, like to identify the abnormal moles. So yes, skin cancer screening, your regular doctor can do it. Like, if there is a suspicion, you can always go to the next step of going to the dermatologist. But once you have one skin cancer, you're probably better off going back to your dermatologist once a year to make sure, because your body has declared that, it don't have all the fight to prevent you from getting cancer. That's why you develop the cancer.
So you're predisposed to it. And there's a problem with dermatologists too. There are too few of them. I had a skin screening with a very prominent local dermatologist here, and I asked him, well, when could I have an appointment to see you? And he said, January. And it was the next year. It was a year and a half away, January, to get this. So just like there's a shortage of gastroenterologists for routine colonoscopy, there's a shortage of dermatologists. And it's important to point out that you can get melanomas in places where the sun don't shine.
That's right.
It's not just a sun-related issue.
We have completed talking about the breast cancer screening, which also, like, you start at age 40 every other year, after the age 50 once a year.
With a mammogram. And a breast exam too by a competent physician, or a mammogram.
Generally, it's the different agencies for prevention, task force prevention of cancers. Like, they said it is the least productive of the screening breast exams.
So the breast exam, because there's little lumps and bumps in there, and it's really hard to tell what's a cancer.
Complement your mammogram, definitely. Like, there are some people, like, the mammogram can be normal, like in almost like in 1 in 6 breast cancer patients.
Yeah, and I've heard that a clinical exam will find perhaps 15% of things missed on mammogram.
Yeah, so that is why, like, if somebody feels a lump, even if a negative mammogram, we would recommend them to go and get a biopsy through a surgeon.
Gotcha. So now I've talked about, and let me to unpack the screening for breast cancer a little bit, because you might notice that the recommendations in Canada might be different from the United States, which might be different from Europe and whatnot. And perhaps you can help us understand this. When you get a test, there are true positives. You've got a cancer, they find it, Mrs. Smith, that's what you have. There are also false positives. Mrs. Jones might have something on the mammogram. She's afraid it's cancer. The doctors are afraid it's cancer. Go in and do a biopsy, but it's not cancer. And that was what's called a false positive, which costs money and scares people to death and uses medical resources. So people, maybe I'm explaining this enough, that these are not black and white, you have it or you don't. There's always false negatives, false positives. So you may hear different recommendations from different groups, but it's not because they really disagree on the biology. They disagree on the allocation of resources and how many false positives will we accept in order to get the true positives. Is that accurate, Uma?
That's really a good question. So the idea is that, you want to detect cancers which are going to be serious enough for the patients. That's why we do the screening mammograms. So when there may be some cancers which may grow slow to the point that it may never be a problem for that patient. Who is that patient? Nobody knows.
Mm-hmm.
So that is where we have a lot of problem in identifying the slow-growing cancer versus the fast-growing cancer. The best, just to not go away from the topic, the best example is the prostate cancer screening with the PSA.
Okay.
So in 2013, the United States Task Force Prevention for the Cancer, they said, do not do PSAs anymore.
Almost 10 years ago, they said, stop doing PSAs?
Yeah.
I must have had 5 in the past few years. Explain.
The reason for that is, if you have a lot of elderly people with prostate cancer, they may not die from it.
Sure, because it's slow growing and something else will take you out.
Yeah. So, those patients would have had treatment that may not needed for them.
Right.
So they looked at the data over a period of several years, and then they found out treating a lot of early stage prostate cancers in some people may be harmful than beneficial.
More harm from the exams and the surgeries and the needles and the radiation, all these things, the cost, the fear.
So they stopped recommending, but we still recommend, if somebody has a family history of prostate cancer, so we would recommend for those patients still. So they put it out in a way that you discuss the risk benefit with your doctor. That's the way they put it out. They said across the board, you don't have to do it. So mammogram is across the board, we recommend it. How often we have to do it, there is a controversy between the ages of 40 to 45. Or even after the age of 50, how often you have to do. Canada says maybe 1 to 2 years.
Right.
Use your, patient's family history, the risk, and then decide that.
So these are very difficult decisions, Uma, which generally require a very experienced physician to guide us through. So I've talked about screening for breast, skin, colon, prostate. Now, what is very exciting, cutting edge technology are perhaps blood tests looking at other cancers that have been very difficult to screen
Before
for.
we jump on, let's not
Please.
ignore the elephant in the room, which is the lung cancer.
That's what I want to hear about.
Which is the most deadly cancer. And now we do recommend lung cancer screening for former smokers who have smoked more than 20 pack years. If you smoked 1 pack per day for 20 years, that will be 20 pack years, or 2 packs per day for 10 years, that will be 20 pack years.
Good.
Yeah, 20 pack years of smoking, and you quit smoking or you continue to smoke, you would be eligible for lung cancer screening.
What is lung cancer screening?
It's a low dose CT scan of the chest that you can get one every year or every other year.
A CAT scan. So you get in a CAT scan tube and they CAT scan your lungs. Now, CAT scans are much quicker nowadays, aren't they, Uma?
Absolutely. Yeah.
So they're real quick. You get in the tube, you don't have to get claustrophobic. It's over with very rapidly.
Very rapidly. So it's not a one-time screening, so they found out, if you do lung cancer screening, we can cut down the death for lung cancer almost like a third now.
A third decrease with these CAT scan, low dose CAT scans.
The problem with the same thing, just as a PSA, here you may find a lot of people with the smokers, some scarring. You may have to biopsy those scars. You may have to do a PET scan for those scars. So there is a little bit of lot more false positives in the lung cancer screening compared to the other cancer screening. So, but it is recommended, and if somebody can motivate it to do it, we see some of our pulmonologists aggressively doing this, and our family practice doctors also starting to do this more often now.
Thank you for mentioning that.
Because the awareness for the lung cancer is not as increasing as the awareness for the breast cancer screening. It is kind of unusual, if you look at it, because the lung cancer is more serious cancer or more deadly cancer than the breast cancer.
Gotcha. Thank you for bringing my attention to that. So let's go now to these blood tests that are called. Did you have something else you want to add?
One more important screening for cervical cancer.
Cervical cancer, that's the GYN world, yes.
It does prevent death from cervical cancer, and it does cure those people. And another important screening test for them. And of course, now that we have some patient families we have identified with the certain mutations, breast cancer and mutations, BRCA mutations, and so those patients have a higher need for a higher screening compared to the normal people.
For cervical cancer?
Not breast cancer.
With breast. Okay.
Pancreatic cancer. You need, there are certain group of people with genetic conditions. They need a higher screening for multiple cancers.
Right. And they have panels for these. BRCA being one of the more famous ones, but you can get a panel to see if your propensity or your risk for cancers is higher than the average.
So the question you were trying to ask before about the blood test for the cancer screening. So it's a very fascinating area right now. So now we understand before we can see cancers as a lump in the body, or it can give symptoms in the body. They can have the circulating DNAs of the cancer cells that we can detect and identify them much before it can start giving the symptoms.
This is very exciting, Uma. Please tell me more.
That's a blood test you are talking about, like where they can identify like hundreds of circulating DNAs which have been attached or identified more often in certain cancers. And they can come up with a score as to after they do the blood test, okay, you can have this cancer now, you need to go for more testing. So, say for example, like if somebody had breast cancer, you can identify some circulating DNAs of breast cancers in this sample. So, this may proceed like, even the mammogram finding of your cancer. So that is a major downside of doing this test. Like, the patient has cancer, but you don't know where it is.
So this blood test might tell you there's some cancer, but it won't tell you the exact type?
It will lead it to like, yes, you may have breast cancer, you may have colon cancer, you may have lung cancer, you may have pancreatic cancer, you may have ovarian cancer.
Okay.
But when you go and screen them, look for it, they may not even have those cancers.
You don't know where it is.
They may not even have it as a lump. So what are you going to treat?
Okay. So they have it, but it's microscopic. There is no tumor, solid target to go in and take out.
That's right.
Now, that opens up a whole nother can of worms. So, will it get to a point where you can give a specific chemotherapy, even though it's microscopic?
No, we don't even know they have the cancer, which is going to be serious to them. So
so it might just be lingering. It might be there, but it may never cause a problem.
That's right. Our body's own immune system constantly fight the cancer cells for every normal people.
So this is an ongoing battle. The body can identify normal and abnormal. And is that one of the ways that cancer gets through? Because the body doesn't recognize it as a foreign invader.
Absolutely.
That's why it's so tricky sometimes.
It's tricky, yeah. This is a good segue to go into the immunotherapy, what we have available these days.
Oh, he's reading my bullet points on my whiteboard. Oh, thank you, Uma. This is perfect. So we've identified that there is a particular cancer. And like I just talked about, the immune system may not recognize it as foreign, and it can continue to grow and cause problems. How can we now teach the immune system or direct the immune system against this thing that was essentially hiding in plain view?
Absolutely, yeah. So let's just to give an example, like let's talk about the melanoma, which is where the immunotherapy started making big strides in the treatment and improvement.
Yeah, and let me just say, melanoma, let's say 20 years ago, was horrible. They had almost nothing. They tried basic chemotherapies, did not work. And I remember there was, I forget the gentleman's name, but he was almost ostracized as a leader in saying that I can give immunotherapies. I forget his name. I know he caught a lot of heat when he came up with this, but then they started showing dramatic results. You may know that doctor's name. I also know that they had the idea of taking the white blood cells that were in these cancers and pulling them out and stimulating them and growing them, and using those as white blood cells or immune cells, at least had some idea, some recognition of melanoma and growing them for some kind of therapy. So that was the earliest. So now we're in a whole new world of immunotherapies for melanoma.
Absolutely. So our body has a very good defense mechanism against cells which are turning into cancer cells in our body. So we have this cell called T cells, which identifies any foreign antigen which is not native to our body, including the cancer antigen to recognize, and then it can selectively target it and kill it.
Okay, so an antigen for my listeners here is usually a protein that shows up on the surface of the cell that makes it a little different So it can be a target of the immune system.
That's correct. So, we have a lot of autoimmune conditions like lupus, rheumatoid arthritis, where our body sometimes starts to fail to recognize those are our normal cells. So it starts attacking the connective tissues.
So the body can attack itself in these autoimmune conditions.
So this is where, the melanoma cells generally our immune system can eliminate the melanoma cells with the help of the T cells. They identified that why are the T cells not recognizing the melanoma cells? So they identify certain receptors called the programmed death receptor, PD, programmed death receptor.
PDRs.
PD1. PD1 receptor, PDL1 ligand receptor. Okay?
PDL1 receptor. Okay.
The PD1 receptors. So there are two kind of receptors which are very critical for this cancer cells to evade our immune system. So they develop antibodies which is to attach to those PD receptors, so that PD1 antibody, PDL1 antibodies, when they develop those antibodies, the T cells were able to recognize the cancer cells better in the body and then kill those cells.
So let me clarify this. So you're saying drug companies have been able to develop these antibodies.
Yeah.
So you give the antibody, it homes in on and sticks to just the bad cells, and then the immune system can come in and identify them?
Identify them and attack them.
Oh, directed, and I love that. I love that. That's so elegant.
Yeah. And so the PD, the PD receptors also expressed in the normal cells. So you can get the side effects of this, enhanced immune system in our body in the form of it can pretty much attack any organ in the body. So because we have those PD receptors like in most of the cells in the body. So depending upon the level of expression in any given individual, you will see the different side effects from the immune system attacking those organs.
So it's not a perfect selective target. It's better than what you have.
It does, so let's step back, say for example, somebody has a stage 4 melanoma.
Okay, stage 4 is advanced. It's all over the place.
It's spread to the lymph nodes away from, where the melanoma is, or it has gone to the other organs like lung, liver, or bone, or even brain. Okay?
It's getting real bad.
Yeah. So that's, when you give these drugs to those, PD-1 antibodies to those patients, so it selectively goes and starts killing those melanoma cells all over the body. So it can cause some side effects. So the common side effects would be in the form of attacking the GI tract in the form of diarrhea.
Okay, your bowels could have these receptors. Okay, so the bowel takes a hit.
And then your skin can get rashes and it can have itching because your skin PD-1 receptors are getting attacked.
You've got melanocytes all over your skin. Okay.
It attacks them a little bit. So it can attack the liver, it can attack the kidneys, it can attack the lungs, it can attack even the brain sometimes. And it can cause joint pains because it can cause, but the side effects are less compared to the benefit you get out of this treatment.
Okay, because otherwise you're going to die from this melanoma, most likely.
Yeah. So, the best example is President Carter.
Jimmy Carter.
Yes.
Tell me about Jimmy Carter. I know he's in hospice right now.
He had stage 4 melanoma. He received his PD-1 drugs for a couple of years.
Really?
That's what kept him alive all this time.
And he continues to swing a hammer and build houses until to the end.
Yeah. So he's the best example of, a good survivor for melanoma. So this immunotherapy, which is started off in the melanoma world, they were able to improve on it, and then now, the important, the liquid tumors or the hematologic malignancies like lymphoma, leukemia, we are finding immunotherapy for those patients in the form of a newer therapy called CAR-T therapy. CAR meaning chimeric antigen receptor.
Okay.
T-cell modified treatments.
All right, let me translate this into English. one of these immune cells, one of these, I'll call it a T cell.
Yeah.
There's different types of T cells. I'm going to try to grossly oversimplify it here. For them to kill a foreign invader, they have these antibodies or these receptors on the outside of the cell that are made partly from a type of antibody. And they're supposed to stick to the target and then in various ways kill the target. However, these cells will frequently not identify these cancers, especially when they're in the blood and they're all over the place. I believe the technology is such that these normal antibody receptors in the surface of the cell can be enhanced by making a synthetic receptor where it still will stick to that target with a piece of the antibody, but it's now connected into the inside of the cell with a different signaling was called a domain. So now instead of using the traditional receptors, you can modify these cells to make them stick and attack these cells. And they've been called, I believe, a living drug.
That's correct.
Very exciting. Tell me more, please.
So, we talked about this immunotherapy, the PD-1 and PD-L1 antibodies. So those drugs have found a way in variety of cancers. You name any cancer in the body, we are using that these days. Breast cancer, lung cancer, bladder cancer, and any cancer which has a deficiency, we call it a molecular repair deficiencies, we can use the immunotherapy for those patients, the colon cancer patients. And pretty much immunotherapy has found a way in most cancer treatments now for, if you have somebody with a lung cancer these days, stage 4 lung cancer patients, they may not even get chemotherapy anymore. They may just get immunotherapy combination.
Wow.
So this is the immunotherapies change the game, and the toxicity and the tolerability, efficacy of the cancer has improved significantly in the vast number. So, now, a step up from, years ago for, say, somebody had a condition called lymphoblastic leukemia, which is a special type of leukemia which happens in the kids more often than the adults.
Yeah. Childhood leukemias used to be devastating. When I was a kid, I remember a classmate started bruising and was dead. It was a kiss of death. There were no good therapies back when we were kids.
So those, kids were getting real high dose chemotherapy. Some of, maybe 3/4 of them were getting cured, but 1/4 of them are not cured, they're still dying. So what they came up is, around the same time is that what can we do, for this, kids, how can we stop them from dying from this deadly disease? So the scientists out of Philadelphia, they started working on a novel variety of identifying a treatment, where they thought they will take their T cells, modify them, and give them make them identify the cancer cell antigen, and then grow that particular type of T cells outside the body and infuse back to them.
Okay, so you take them out, essentially educate them, modify them, and it's their own cells that have been modified that then are injected back into their bodies.
Yeah. So that is the concept of the CAR T cell therapy. So they found out it was curing half the people who failed the chemotherapy.
Half. So of those that were failing, they got a 50% reduction in death.
Yes.
Wow. Cured.
Yeah.
Spectacular.
So this concept was started in that particular disease. Now that is expanded into more and more disease now. So now we have people with a non-Hodgkin's lymphoma, which is a form of lymph node cancer.
Okay.
And people who have multiple myeloma. So they have those treatments available for them. years ago, when these patients failed all the available chemotherapy, it was pretty much a death sentence for them that they're gonna don't have any more option. Now we have this CAR T cell option, which helps them to, at least it cures like 50% of their cancer patients, for them to live a productive life. But it does come with the side effects. It does come with the high cost of the therapy, and but things are going in the right direction for the cancer treatments. And this same concept may be coming on to pretty much most of the other cancers, like maybe lung cancer, breast cancer, all those kinds. This CAR T cell therapy may be coming on to the other cancers which we don't have a good treatment.
So is it true that cancers that we used to consider very different, maybe a different animal, might in fact be similar enough or have the same molecular susceptibility so that a treatment for something such as lymphoma might, maybe it's not surprising, would also have effectiveness on a solid tumor?
That's correct. Yeah. So because our understanding of cancer has gotten better. We understand cancer is, if it is not say somebody has a lung cancer. There are no two lung cancer patients have the same growth promoter. In other words, they have cancer. We know that, but one person's cancer is growing because of certain mutations. The other patients, say EGFR mutation in one patient, and ALK mutation in another patient has a RAS mutation. So we have another MET amplification which causes cancer in certain people. So we are understanding what causes the particular individual's cancer by running a test called the next generation sequencing.
Okay.
So we take on the biopsy or after the surgery, we have the sample from that particular individual. We will send them off. So we identify what is promoting that given individual's cancer growth, and we can use that particular treatment for that individual.
That is so exciting. That's called personalized medicine.
Personalized medicine, targeted therapy.
Well, that is so exciting. And everyone can be a little different. It's a spectrum of these many different mutations. And I want to put another finer point on this. Our body has this amazing mechanism of growing when it's supposed to and not growing. Like, for example, you cut your finger, it releases all these factors, it starts growing like crazy, heals up, and then stops.
That's right.
Incredibly, infinitely complex pathways. And it's not just stop and go. You can have an inhibitor of a growth factor. You can have an inhibitor of the growth factor. And it's the same way in hematology with clotting. You want your blood to be liquid, yet you want it to get solid and clot when you want. So you have these immensely complicated chains and pathways that somehow you need to decipher, Uma.
That's right. So let's, because we talked about the target therapy, let me kind of go back on one of the common cancers, which would be lung cancer.
Please do.
So lung cancer traditionally, diagnosed in late stages in majority of the patients because lung is a big organ. It can let the lump can grow without causing any symptoms for a long time. So that is why screening for lung cancer in smokers would be able to find those early stage cancer and cure them. Okay? So now, once they get diagnosis of cancer because they've been having cough or bloody spits or trouble breathing, those would be the common symptoms from the lung itself they come with for the lung cancer diagnosis. So we take their sample, and about 18 to 20% of the patient will have some targetable mutation. That's like 1 in 5 lung cancer patients. And now they've identified more than 20 different mutations where we have treatment for them.
Wow.
So those treatments are much, much, much better than chemotherapy. So chemotherapy, the response rate would be in the range of about anywhere between 40 to 50%,
Okay.
whereas, or even 35 to 45%. Okay?
The minority.
Yes, minority. Whereas when you give the target therapy, their response rate is in the range of 60 to 70%.
That's spectacular.
Yeah. So when we give this drug, if they, depending upon the how much burden of the disease they have, they become asymptomatic within 2 weeks.
In 2 weeks, their symptoms can go away.
Yeah.
Wow.
How good the target therapy for these patients are. And then, then you get, patients who are weak. Pretty much nowadays, nobody just get chemotherapy for a lung cancer patient. They either get chemoimmunotherapy or immunotherapy alone. That is a huge change in the treatment that I have seen in the last 17 years after coming to Columbia.
Sure.
This is like space age for cancer, I would say, where we have such a good way of identifying patients, and I don't think we are there yet fully. I would be happy to maybe 10 years, 20 years from now to sit here and say, oh, lung cancer is a chronic disease just like diabetes.
Or HIV now. You just take a pill and you live with it like anybody else.
I hope, I think we are going in the right direction, and we need more research funding from everybody to keep studying the cancer, and and patient participation in clinical trials are very important. So only when we study them methodically, then that's when we know.
Now, there is a subspecialty of oncology, hematology, called radiation oncology. A whole nother world. I know you're not a radiation oncologist, but obviously you work with them. Have there been any developments that you know of in radiation therapy? And let me position this like this. Radiation is generally harmful to the body. And if you get your whole body radiated, you damage a lot of things. You're not helping anything. They've been getting better over time, called coning down or focusing radiation. And imagine you have a tumor here. Well, if you can hit it at this angle and then maybe rotate it and change the beam a little and hit it from this angle and then rotate it and change, everything else around gets a lower dose, but your target itself gets the higher dose. Or have there been developments or improvements in targeting tumors by our radiation oncology colleagues?
Absolutely, yeah. So radiation is still in certain cancer could be primary treatment. Meaning, if they have a one place, say for example, somebody has a lymphoma, stage 1 lymphoma, they can just get radiation, don't have to get chemotherapy.
Really? No chemo at all?
Yeah, for stage 1. Okay. And, the surgeon would have removed the one lymph node, which had cancer, the lymphoma in it. So they can just get radiation there. Okay. So still radiation is a curative for certain conditions. Okay.
Really?
Primary therapy. It's not gone. Okay. So majority of the radiation that we, like prostate cancer, so still if somebody don't want to have surgery, you give them as a primary treatment. So it does work. And then for breast cancer patients, so the way the treatment, local therapy for breast cancer is lumpectomy plus radiation is equal to mastectomy. If you do mastectomy, you don't need radiation most of the time, unless you had a lot of lymph node involvement. So radiation still has a place in a lot of treatments. And as far as focused radiation, yes, absolutely. The technology has developed really over the last several years, where say somebody is 83 years of age, they are in really bad shape. They had 3 centimeter lung cancer. They're not a candidate for surgery.
So they're just surgery could kill them.
Right.
The actual surgery itself would be more harmful than what they have. So they can avoid surgery with this sometimes.
Yeah. So they have done studies comparing, can we just do focused radiation or should we give them a regular radiation? So they found out focused radiation which is 5 treatments.
Wow. And avoid surgery completely.
So, the 3-year survival for the patient is 50%. That nothing happens to them.
Wow.
So, those are all the, and then, the radiopharmaceutical therapy is improved a lot these days.
So let me explain what a radiopharmaceutical is.
Yeah.
It's a compound that has radiation, or an isotope, one of these things that emits radiation, and it can be connected to something that you could give in your blood, but it homes in on it and it targets those abnormal cells. So please explain that more to me.
We have, initially this treatments were developed for lymphoma patients where they can target an antibody called CD20 antibody, give them, and then compound it with a radionuclear material.
Sorry, so you have your key, the antibody, with the radioactive material, you put it in the blood, and it sticks right where you want it.
That's right. Yeah. So that was a treatment started for the lymphoma. Now we have some similar treatment for prostate cancer, where we can give that, and also so one of the treatment for the very rare type of pancreatic cancer called neuroendocrine pancreatic cancer.
Okay.
So those patients have a treatment called Lutathera, where they took the octreotide and then attached to a lutetium, which is a nuclear material.
Okay.
So they give it to the patient. So that really makes them live really long.
So it's very focused. Because let me just tell people, the pancreas sits in the middle of the abdomen, behind the abdomen, and it is wrapped by the spleen and the liver and the stomach and the lymph nodes and the big blood vessels. The pancreas is a very difficult organ to get to surgically. It's a very fragile organ. It's very hard to work with. So you're telling me they got this targeted therapy. You can give an intravenous injection, and it can find these neuroendocrine pancreatic cancers.
Usually we do it first after it is spread to the other organs in the body.
So now it has spread, and you can target these metastases or these tendrils that have gone elsewhere in the body.
So we have focused radiation in the brain. So say somebody has a cancer travel to the brain, so you can give focused radiation so that you don't affect the neurologic functions of the other sites in the brain. And that seemed to have been maintained the cognitive function for our patients.
Uh-huh.
So years ago, we would give them, whenever cancer spread to the brain, we would give them the whole brain radiation. Pretty much we stopped doing the whole brain radiation unless you have more than 13, 14 metastases. If it is less than that, we can just target them individually so that their cognitive function stays intact.
Sure.
And then you can, that is a big improvement on the quality of life for those patients.
Spectacular. So
radiation, as and then the other important radiation, they developed is a proton technology. So proton, technology, when you give radiation with the proton technology, the amount of spill away from where you are targeting will be less. Okay. And also it does slightly have less side effects compared to the traditional electron beam therapy radiation. Okay. So, but it is about 10 times more expensive, so that's why it's not widely adopted yet. But it is being used only for pediatric cancers right now. And for some of the adult cancers, it may get approved, God knows when. But obviously, if you get the same outcome from 10 times less expensive than the...
Sure.
So nobody's going to pay for that unless you can come up with that money.
Got it. Yes.
Which is ridiculously expensive.
Now, I'm going to just completely ignore the cost of cancer therapy. It goes far beyond what I'm prepared to talk about today. Sure. Obviously, it is an issue, and public health people will say, well, look, we've got $1 million to spend. We can spend it on one person, or we can improve the sewers for an entire community and save so many more lives. So these are very, very, very difficult decisions, obviously. So Uma, are there any other tests coming down the pike for cancer that I have not talked about yet that we should talk about today?
We talked about the screening test for breast, colon, cervical cancer, lung cancer, and those are the standard testing. So there are people are coming up with years ago. I was doing an interview for a local news company about the similar blood test we were talking about, where they can identify um, markers for different cancers. And but this was like you're talking about 9 years ago.
Yeah.
We have those technology come and go, mostly because we are not sure how to perfectly or connect them to the clinical practice. Where there is a recent, like there is one company recently said, oh, we can identify every cancer by doing our blood test. Yes, you can, but there is an issue as to okay, you're going to tell, look for this cancer. What if you go and say if you have 1,000 patients who got the blood test, like, oh, this many patients have cancer in them, you may not find cancer in, half of them or none of them. God knows that. We need to have more research as to people to participate in. Okay, we're going to do this test. We're going to identify, see what comes out of the out. We need to look at the outcome in a very rational way instead of getting excited about ordering those tests.
Yes. Tests are not black and white, and they can sometimes cause more problems than they solve.
Anxiety too. Yeah.
Anxiety, cost.
Yeah. And then so that is the reason why we need to be careful as to use the technology what's been well studied and what is not going to harm the patient.
Yes. So I think the take-home message here, there's several of them. One is that the field of oncology is advancing rapidly. Success rates are getting better and better all the time. Very exciting developments are on the horizon. Your job is very difficult keeping up with all this stuff. But the word cancer is not a death sentence, and people should not be afraid to be screened, because the sooner you catch one of these things, the sooner you can potentially have one of these life-saving treatments, which is frequently just a drug or an infusion and not some type of huge surgery.
That is, I agree with that. We want to detect the cancer early and take care of it early. We don't want to delay the diagnosis or ignore your symptoms.
Okay, well, I'm going to end this on a personal note, Uma. I spent some time when I was younger with a psychiatrist from Harvard. His name was Richard Alpert. And in the 60s, he changed his name to Ram Dass, which loosely translated, it means servant of God or the divine. Your name, Ramadas, is obviously very similar. I have great respect for you, and you do very, very special work. You touch the lives of hundreds of people. I was in your clinic a few months ago. I don't have cancer, but I was getting screened. There's stuff that runs in my family, and I saw one of your colleagues. And I went in the office. I just expected an office and a reception area. I went in there, went around the corner, and it was like an athletic venue. It was enormous. You've got all these divisions and the blood and then this and then that. You have an enormous practice, Uma, and you have fantastic colleagues. You're a great resource for our community. And I just want to say I admire you very much. You have a very, very special job. You perform it well. And I just want to say I'm very grateful for your time. I know I pestered you to come here, and you finally found some time in your travels and in your busy schedule. So I'm very, very grateful and thankful for your time and your insights today.
Thank you, Gil. I'm more than, it's a pleasure to participate in this kind of discussions. Community awareness is very important, and more people are aware what's available, and they can utilize it better. And Thank you again. Thank you for inviting me.
Thank you for your time, my friend.
Thank you.